What's up, guys? Are we live? Got to figure this out. Never quite know with the technology. It's ZDoggMD. This is the ZDoggMD show live. Here's the thing. Normally I go live just to supporters on Facebook because that's what we do. But today I want to go live to everyone. And just for people to understand, if you support the show, you subscribe to the show, the $4.99 a month nonsense, I usually am going to be going live around 4 p.m. Pacific, 7 Eastern, and whatever Central, generally from now on, with some variation depending on whether I'm traveling or I just decide I want to go live, because spontaneity, my friends. So I hope you're having a great weekend. It's around 4 Pacific. Thought I would check in with y'all because, and I wanted to check in with the whole page because we've been talking a lot there's been a lot in the news on this coronavirus. We've been talking about pharmacists and how the large retail chains may be leading to more errors by mistreating and commodifying pharmacists due to the incentives, the financial incentives that these large chains are under in order to squeeze more and more out of less and less as the margins shrink, and the overwhelming response to the piece I did on that. So I wanted to talk about that. I want to take your comments. Let me pull them up on my handy dandy thingamajigger. I guess it's called a laptop. I don't know. My people call it Maze. Let's pull it up here. Open that. Come on, my friend. There it is. Perfect. Okay, so David Griffin's here. Erica Black, supporter. JTA's here, supporter. Supporter Michelle Morgan is here. All right. So the thing, let's jump into this Wuhan Coronavirus thing. By the way, any Chinese person, including my wife, who hears me say Wuhan, says my tones are way wrong. My Mandarin is not top-notch, my friends, my tribe. So this is the thing. From the beginning, I did a video a while back of saying, hey, there's this really big media response to this thing. There's a huge Chinese government response to this thing compared to, say, SARS, where it was 100% covered up. Now it was only like 60% covered up. And, you know, we read the article recently, and I shared it about that Chinese Dr. Li, I think Wei Ling, I forget his last name. It doesn't matter because he's a hero. Succumbed to the virus, was the original guy who sort of sent to his medical school classmates, hey, there's this new thing coming out of this seafood market in Wuhan. It looks like SARS. You should just be cautious. And then he said, you know, it looks like a new coronavirus. Well, he was right. And the Chinese government not only censored him, took down the post, but made him sign some confession that he committed a crime. And ultimately, he took care of patients in that area, got sick from one of them. His wife, who is 8 months pregnant, he has another child. His parents, I think, who are infected, recently died from this virus. And it made me so upset to read that article emotionally because, and there was a beautiful cartoon someone shared about it where you have an angel with a mask caring for a patient, and then the hand of the government just snipping the angel's wings above that. And that is really what it feels like when frontline healthcare professionals are silenced by anybody, industry, government, their own, it doesn't matter. And that was what was happening here. And so it was really this kind of tragic, horrible thing that the Chinese government did to this poor doctor who is now deceased. So I think we as a tribe have to stand up and say, never again. We can never condone that kind of behavior from our frontline, you know, against our frontline caregivers. Now the question then is, the next thing we need to talk about is the coronavirus. Let's read some comments itself, all right? Let's read some comments. So Ken Chaffin, thank you so much for your support of my fellow pharmacists under stress. Stay tuned, Ken. In the second part of this, I'm going to talk more about that, okay? Because there's been such a crazy response to that piece, and I think we need to go deep on that. Carrie Clifton, use go.go and search whistleblower. There's more information available without bias. So when it comes to the coronavirus thing, there is so much panic and misinformation online, so much. And remember, you're never going to get all the information correctly anyways because we're dealing with the Chinese government. We're dealing with the government in general. But it was quite telling, I think, that the U.S. public health agencies, the WHO and others, were slower to declare this a public health emergency. China shared genotype information on this virus. They did unprecedented things that really very few other governments could do, like shut down entire transit hubs of 11 million people like Wuhan, do pretty draconian shit that you really, like it'd be impossible to do in America, right? In fact, the first quarantine in 50 years from America was issued against American expatriates coming back from China during this coronavirus thing. And this is my take on this. Now, understand this. I don't pull this shit out of my ass. I talk to people at the highest levels, okay? So this is not just total BS information. First of all, stop panicking. If you're running around wearing a mask in the middle of, Peoria, you're just wasting masks, okay? Second of all, wash your hands, and that's a universal edict, okay? Third of all, let's talk about coronavirus in itself. Okay, it arises, they think, from an interaction between animals and humans, live animals and humans in a seafood market in Wuhan. It quickly either already had the ability while in the animal or once transmitted to human, zoonotic transmissions, from animal to human, and gained this ability to go from human to human. And the level of transmissibility seems to be more transmissible than influenza, than standard influenza, right? But less transmissible than something like measles or chickenpox. So somewhere on the spectrum, it's, not terribly transmissible, but more transmissible than flu. Now, why does that matter? Because you also have to look at how fatal it is. So we have this coronavirus, and by the way, coronaviruses can cause colds, or they can cause things like SARS and MERS. So there's a whole spectrum of virulence, right, and transmissibility. They have again, it's pretty transmissible, though not the most transmissible you can be. It's transmissible enough, but fatality rate seems to be so far between 2 and 3%. That is quite a bit less on a logarithmic scale. It's quite a bit less than flu. Sorry, not flu. It's quite a bit less than SARS or MERS or Ebola, right? Those are like, I think MERS and Ebola are like in the 40-50% range, right? SARS was in the 10% range. Influenza is around 0.1%. It's like 1 per 1,000 people infected will die. Why is influenza worse? Pop quiz. Because influenza is so widespread that, in a year, 35,000 Americans can die from flu. Like it is catastrophic in scale compared to what has happened so far with coronavirus. So just put all these risks in a context. So knowing that this is a virus that we don't have all the information on, it may be 2 to 3% fatal, we don't know, and these fatality measurements are poorly understood for a couple of reasons. The first is, think about this. This is a virus who in 85% of people may cause mild illness. You may not even have significantly aggressive symptoms. So you're trying to now, as a government or a public health official, calculate what's the fatality rate. You don't even know what the infection rate is, right? So right now they're talking about 20-odd thousand. I forget how many we're up to now, and 700-odd deaths, something like that. It could be that the infection rate was 50 or 100,000. We don't know, because many people may not even be able to be counted because they're overwhelmed in China, but also that mild symptoms may not actually be counted as this and tested as this virus. So the fatality percentage, the rate of fatality, may actually be lower. There's a small chance it could be higher if we're just not counting enough fatalities. In other words, people are dying, but they're not being counted. And again, since we're not there on the ground, although some are, the sense is that we just don't know entirely. My intuition is saying that probably the fatality rate is a little over-reported. Still, it's high, all right? So you take it very, very seriously. Now, I've talked to people, Chinese doctors on the ground there, and they say, yeah, it is a mess. The resources are pulled thin. It's very hard to respond. Resources for other health conditions are being compromised. And people are, the inability to be transported around, all those other things it's quite draconian. Now, remember, that is the Chinese government response. People really, really, really want to say, oh, this is all horribly managed and so on. Listen, it is very hard. And I'm not defending the Chinese government, people. I'm saying that preventing a pandemic is hard as hell, all right, when the thing comes out and it's transmissible like this virus. The fact that it's been slowed, the fact that we're going to have time, we're buying ourselves time now before the thing really explodes out of mainland China, if it does, right? Because remember, SARS, they ended up, the transmissibility and the fatality rate and the fact that they were able to, there's another equation here, right? How long does it incubate for? So in other words, how long can you, after being exposed to the virus, does it take to show symptoms and be transmissible, be infectious? Well, with SARS, you could actually have symptoms in 5 days, incubation period 5 days, and actually not be transmissible until later in the disease. In this one, it seems that the incubation period can be up to 2 weeks, and we don't know when exactly you're infectious, so it could be before that. So you may have minimal symptoms and be infectious, which makes it much, much, much harder to control. With SARS, they were able to actually recognize in a global way, okay, oh, that's a case of SARS, isolate, and pretty soon, given the dynamics of those epidemics, you were able to actually control the outbreak. And even though they were working on a vaccine and all that, they never really needed to mass deploy it because the outbreak kind of burned out and went its course. With this, we're seeing maybe a different pattern. So a lot more cases. With SARS, it was like 8,000 cases, 700 deaths, something like that. With this, we're already above 20,000 cases, 700 deaths. So we're seeing a much bigger spread. It's very hard. And compared to SARS, we're now in a position where China is much more connected in terms of infrastructure of travel. So there are so many more, order of magnitude more people able to travel while infected, which is going to change the dynamics of this. So does that mean that we should panic and go crazy? And there's so much like also xenophobia and racism showing up. It's like, let's pump the brakes. Flu is still killing so many more. I had a person on the show yesterday who studies malaria. She's a fourth-year medical student, pediatrics, I think, wanted to go into pediatrics, MD, PhD, studies malaria. Something like 30 children, like a minute worldwide, can die of malaria. It's some ridiculous statistic. And there's no massive media outcry on this. Now, I'm not saying that you don't take the coronavirus very seriously like they are. I'm saying let's put everything in perspective and do the best we can and understand the limits of human beings to sometimes completely control something like this. And so far, the efforts have been very, very serious. And if I'm listening to my intuition on this and knowing the people involved, they will bear fruit to the extent that we will slow the spread of this, which will give us time to do a couple of things. One is prepare, particularly an international hospital response, which means building up resources, training, understanding the dynamics of spread and the contact and airborne precautions, the other things that we need to do to prevent transmission. Because what we saw on the ground in Wuhan is a lot of healthcare workers getting sick, usually from and it seems like there are super spreaders within hospitals. So a single patient infects 17 healthcare professionals and other patients. There was such a high prevalence of the disease happening within the hospital. And again, there may have been a slow response to this. It may have been they didn't understand how to control it, and then errors can happen. Remember the nurse who in the U.S., in Texas, who was exposed and contracted Ebola. So similar ideas that our healthcare professionals, our tribe guys, are vulnerable to these kind of things. That's why we cannot be a part of a hysteria. We have to be part of a very serious, directed response where we're speaking rationally. That means you don't go on Twitter and see pictures of people in China passing out and hitting their head on the ground and going, look what's happening over there. It's like Stephen King's The Stand. It's Captain Trips, man. That's not how we behave. That's irresponsible. It's wrong. And it's harmful, actually, to the actual response. Okay? So, understanding that we'll have time to better respond from a hospital standpoint, we'll have time to slow the dynamics of spread so it doesn't become so exponential that we are pressed to respond resource-wise. And the third thing is now we have time to understand the science better. So that will mean understanding those dynamics that we talked about earlier and starting on a vaccine. And this is where the anti-vaxxers roll their eyes until they realize that they're terrified of this thing and they would be the first in line to get a vaccine, right? And the same, and there's some thinking, actually, I had Peter Hotez on the show, world famous vaccine researcher, and he was talking about the recent re-outbreaks of Ebola may well have been attenuated because of the use of the early Ebola vaccine. And people don't talk about that, but it's a big deal. So time to spin up a vaccine, which at minimum is a year out. Like, you need to do clinical trials in as early as 3 months, but to really prove it's safe and effective, it's going to take, in an emergency setting, at least a year, probably longer. So getting the jump on that, and then understanding too that the dynamics of the viral spread may change with the seasons. So trying to run out the clock on this winter season in the northern hemisphere where people are clumped together, where the virus may live for longer. The other thing you got to know about this virus is it's spread by these heavier droplets that tend to fall off within 10 feet of the person who's infected. We don't know how long it lasts on surfaces. So again, washing hands, right, is a key thing. Not touching your face. Those kind of things are very important to the dynamics of this viral spread. All right, let's read some comments. Sandra Bradfield says, are we still on for March 5th? Yes, so we're doing the thing right. Doctors, whoa, what happened there? Hold on. There we go. Doctors Speak Up, March 5th. I did a show about that. I'm going to actually have a couple guests on the show talking about that, where everyone, it's not just doctors. I use Doctors Speak Up because it was easy to write. Really, it's all of us. The healthcare tribe speaks up about what we think about vaccines. And we are going to overwhelm and break the internet with positive education and positive vibes on the science of keeping our children safe on that day. And I think it's good. It's good, actually, that it's in the context of this horrible outbreak, because it brings an urgency and an importance again to the science. What will we do without our scientists right now? What would we do without our epidemiologists? What would we do without our public health officials? What would we do without our frontline doctors like Dr. Lee, who gave his life to take care of others? Would anti-vaxxers do that for you? No, they would run and hide and put their cowardly heads, their science-denying heads, in the sand, all right? And I'm talking about the cult of anti-vax. I'm not talking about mom on the fence, dad on the fence, someone who's been poisoned by all the celebrity nonsense around this. I'm talking about the professional anti-vaccine cult members who are so deluded you will never get through to them. They are a poison and a scourge. All right, that being said, March 5th, join us. Doctors Speak Up. All right, let's read some more comments. Let's see. You know what? Forget the comments. Let's go to the next topic, because I want to get this out before I get derailed. The pharmacy thing. So there was a New York Times article that I shared talking about how the large chain pharmacies could be hurting patients by overburdening and overworking and understaffing and under-resourcing pharmacists, and imposing on them really a set of business metrics. They're not so much quality metrics, they're business metrics. In other words, how many 90-day refills did you push? How many patients can you see per minute? Or prescriptions can you fill per minute? Are you working the drive-through and giving flu vaccinations and counseling patients and calling doctors to ask for refills and sending refill requests and doing all this? So all these metrics, right, that are then leading to human errors, because that's not how human beings work safely. Business metrics do not help them work safely. They help a large organization make more money. And this article was brutal about the men and women who've died due to pharmacy errors, and the pharmacists who've suffered so much moral injury, having to basically compromise safety to then continue to keep their job. And the fact that they can't speak out or they're fired is a huge problem. The fact that the pharmacy boards in the United States there are members and representatives of the large pharmacy chains on these boards. They have very little power to actually even acquire data on errors that are made. And when they inflict punishment, it's on individual pharmacists instead of on the systems that are creating the errors. And so I did a rant on that, and I have never gotten so many messages about anything we've done. Pharmacists have been going nuts. And I have yet to hear a single dissenting message that said, no, you're wrong. These institutions are safe and they treat pharmacists well. Not a single message. And again, I know people in the highest echelons of all these companies, they're good people. It's the system that is bad. So there's consensus here, and people are terrified to talk about it. The number one thing they tell me when they message me is, please don't share this with everyone, but I needed you to know that what's happening is killing pharmacists and killing patients, and it didn't used to be like this. Or I'm coming out of pharmacy school and I never expected it to be this bad. This is untenable. And we're not even talking about hospital and independent pharmacists, although the independent pharmacists are squeezed by the same metric pressures because they have to make it a business that's sustainable. And then you have these PBMs, these pharmacy benefit managers, that are really devilish, you guys. Like, between the clawbacks and the DIR and these fees and these things they do, they are putting independent pharmacists out of business, and they are ultimately hurting patients by driving up costs. Period. That's it. Let's read some comments. Let's see. Thank you. Love to listen, says Kelly. I'm an OB-GYN NP. Beg my ladies to vaccinate. That's right. We did that piece on vaccines and pregnancy and the ones that you need. Very important. Ken Chafin says, if we made a dispensing error, the pharmacy chain I used to work for made us fill out incident reports using their terminology to describe the cause of the error. We are not allowed to use lack of help, overwork, etc. as reasons for the error. Yeah, that's right, Ken. And in the New York Times article, they actually showed one of these reporting forms. And one of them was, is the patient a media risk? In other words, are they going to go to the media? Come on, you guys. Like, these are human beings we're talking about. You're supposed to improve error rates, but this was the point of that. We don't get paid to give quality care. We don't. We don't get paid to do the right thing. We get paid to churn the volume or do whatever metrics make the parent company or ourselves money. That's what we get paid to do. And that is the problem. Until you realign those incentives, how you're paid. And that's the thing. So we have to make the error reporting mandatory. We have to make real punishments for large organizations that fail to provide systems that are safe and fail to provide quality care. And we have to figure out ways to incentivize quality care. This goes across medicine. A lot of what we do doesn't work. A lot of what we do causes harm. And guess what? We get paid to cause harm. Why? If I cause a complication by doing an unnecessary scan that finds a thing, an incidentaloma, some little lump or bump that we never should have even found because we had no clinical suspicion for it, then I go poking at it with a needle and I end up causing a pneumothorax that ends up getting a chest tube that ends up causing another complication, and the patient ends up sick or with more tests. What happens? I get paid for every single one of those tests. I get paid for the ICU stay. I get paid for the physician visit. How is that incentivizing quality? That's absolutely ridiculous. So that's one thing that we have to, as a tribe, stand up and say, no, we can't. This is not something we can do. All right. Pharmacy boards aren't listening, says Loretta, to patients or our pharmacists. They don't have to. The PBMs and their affiliates make up the majority of the board. How do we fix this? It may require either a groundswell, bottom-up, grassroots campaign across healthcare, so not just pharmacists. Pharmacists are pretty powerless, you guys. Let's be honest. They are owned, most of them, 70% of them are owned by these big companies. How can they speak up, right? I mean, they could form a union, theoretically, but they could also tribe up with the other 13 million healthcare professionals and say, no, we're not going to allow our colleagues to suffer like this, because ultimately the suffering comes to us because our patients get hurt and we are part of a morally defunct system. We cannot continue to practice in a system that violates our morals. End of story. And that means that if our pharmacists are hurt, we are hurt. That means if our nurses are hurt, we are hurt. That means if our young doctors are driven to die by suicide because they can't take this schizophrenic system where they're forced to do things that have no positive impact on patients and may actually harm them, we can't stay silent. And that's partially why we have this platform, because I will yell and scream. You may get fired. Tell me on the back end. I will yell and scream for you. And together, we will have a voice, period. What are PBMs, says Janine? Pharmacy benefit managers. They started out as a middleman to kind of negotiate between, say, pharma companies, insurance companies, big self-funded employers to try to manage their benefit plans for medications. In other words, how much they're going to pay, what formulary they're going to cover, and try to, and it was done with good intent. Now they're a middleman that ends up costing independent pharmacists pretty much their careers. And we've done a show on this, I believe, one with Doc Vader and another with, it might be Deanne Mullins. So we'll have to share those again and kind of get deep into it. I think John Oliver might have done a piece on this as well. It was well done if he did it, because all his pieces are well done. So something to check out. Let's see, we have political division between nurse practitioners and physicians in Indiana. Power struggle. How do you move forward? Cindy Ledbetter. Well, this is the thing. This is the thing about this NPMD thing. Why are we fighting with each other? And yeah, there are bad eggs on both sides of this argument, right? There are nurse practitioners who think they're doctors, and there are doctors who think nurse practitioners are too dumb to practice. And they're both wrong, right? So let's get beyond the fringes on that, and let's look at the fundamental problem. Who benefits when nurse practitioners and MDs are at each other's throats? The big entities that are already running healthcare, because we're distracted from the real problem, which is all our incentives are misaligned, that we don't have the support to take care of patients the way we know is correct, that we're busy clicking in the EHR and the EMR instead, the ECR, the electronic cash register, instead of looking our patients in the eye, and that is a universal problem. Why aren't we on the same team fighting together? Here we are. We're not going to snipe at each other. Man, I get so many messages from angry physicians wanting me to attack nurse practitioners and upset nurse practitioners saying they've been attacked and they should have a broader scope of practice. And I'm like, you know what? I was about to curse, but I want you guys to be able to share this thing. So that's my call to action at the end of this. Please, and thank you, Dee, for sending me stars and supporting the show. Tony Frankie, thank you for supporting the show and sending stars. It helps pay for all the stuff that we do. I want you to share this. Erica, thank you. And I want you to make noise. If you can't use your own voice with your own name, get an alias account on YouTube and start leaving comments on our videos using that. Definitely subscribe to us on YouTube so you get our videos. Join our mailing list. There's a lot of ways to be a part of the movement. All right, guys. I am going to go. I'm going to go have dinner with Dr. Harry, my good time med school friend that you guys have seen in some of the videos. If you're good supporters, I'll try to do a supporter-only show with him tonight, but I gotta sweet talk him. He's kind of an introvert. And you're right, Melissa, we are all on the same side, period, including our leadership. It's just that they are a slave to these incentives like we all are. And if we get them on our side and we're all together doing the right thing for patients and each other, no one can stop us, my friends. No one. All right. 12 million strong, you guys. Come on. And if you count the ancillary support and stuff, like 20 million plus, healthcare, no one can stop us. We're like the most powerful thing in the universe. Why aren't we on this? Why are we suffering so much? We can save the country. We can save the economy, because right now we're part of the problem. Let's be honest. All right. Fudge. All right. Meyer, uncensored on the supporter page here. I got to keep it a little bit on the DL. All right, my fam, I love you. Until next time, have a great weekend. Stay safe. Take that mask off your face unless you work in a hospital and you're taking care of sick patients, or you're going into China. And we out. Peace.